tight website. Perfect. But today I am delighted to introduce Marlene Adams. So Marlene is an occupational therapist at the Lyndhurst Center, and she has 20 years experience in the outpatient seating clinic. Having started her role with little structure or guidance, Marlene has learned the benefit of using guidelines and other resources to support her practice. She has shared her experiences in conference presentations nationally and internationally, and she provides lectures on the wheelchair provision process at the University of Toronto. The title of her talk today is Clinical Applications of Guidelines in Seating and Mobility. So I look forward to the presentation, and Marlene has confirmed that she will take questions at the end. If you have questions throughout her talk, please feel free to type them in the chat, and there will be time after the presentation for her to answer your questions. You may also prefer to just save your questions for the end of the talk as well. So without further ado, I would like to welcome Marlene.
Thank you very much. And thank you everyone for coming today. So 2025 marks 20 years that I've been in the outpatient seating clinic. And so I realize this is probably as good a time as any to share some of my reflections and insights with the rest of the clinical team and the researchers that may be interested. Prior to starting in the seating clinic, some of you may not know that I did work in inpatients for five years. And during that time, I was involved in the early stages of the FES research that was here at Lyndhurst. So I love the notion of frontline clinical collaborating with research. And I'm hoping that all of you can take something away from this talk today using seating clinic as the backdrop to why guidelines and best practices can be helpful. So the goal of seating clinic is to help people get an appropriately set up wheelchair, and that is both challenging and important. Why is it important? I want to share a story with you to answer that question. I had a student from Vienna, Austria, and we were working with a patient who needed a customized foot support on his new wheelchair. So while I was working with the custom seating tech on what our options were and how we were going to do this, I was aware that he was explaining to her what his inpatient rehab process was like. And afterwards, she told me that he said the most important part of his rehab was his wheelchair. That really stuck with me because I had never thought what's the most important part of rehab. And I imagine it's different for everybody. But the wheelchair will have an impact. It can be the difference between being comfortable or in pain. It can affect the level of independence, and it can affect someone's health. If they're sitting in poor posture, they're at risk of falling or a pressure injury. I want to enhance this with comments from Mayan Ziv a few years ago when she was in the news after her power wheelchair was damaged beyond use after an overseas flight. And this is a direct quote from the news article. Her wheelchair was the most enabling technology in her life, and for that, she was forever grateful. An appropriate wheelchair is so important that the World Health Organization has even put out a statement describing what constitutes an appropriate device. It needs to meet the user's needs and environmental conditions. It needs to fit properly, be safe and durable, available locally, and be able to be maintained affordably. So, for example, if I have 3 people on my caseload, all with T4 paraplegia, they will have different needs. The single mother who has to pick up her kids from school every day, no matter the weather, will have different mobility needs than the person on a national level team, who will have different needs from the person working full-time as a chef. Even their mode of transportation can affect their wheelchair or mobility device choice. When I started in the seating clinic 20 years ago, I was on my own. I didn't have a peer with me, and I didn't have a whole lot of resources to draw on either. So I found myself attending conferences and workshops as often as I could, often at my own expense. And I'm hoping that with all the stuff that I've learned over the years and the availability of guidelines and technology that are out there now, that future people working in this field or others don't have to go through the same kind of thing. I'm hoping that you will see how guidelines have enhanced our practice, and I will try to describe them throughout the wheelchair provision process. I also would like to make an impression on you regarding the importance of doing a thorough assessment as the foundation for your practice in whatever area of practice. And throughout, I'm hoping that there will be some considerations that people from various parts of the team and research can take away. So one of these talks that I attended was a lawyer talking about what to do if you're facing a complaint. And one of the things he said was, our opinion is only as good as its foundation. And I thought, that's sort of our product here. In my role, my contribution is my opinion, and the foundation of my opinion is my assessment. So we need to understand what is expected of us from the assessment. You might want to start with looking at, what does your employer say? If there is a policy about the assessment, are you meeting the expectations there? And I would expect a policy, if there is one, to say something like, we operate within the current best practices that are relevant to the field. We need to understand what our funding body expects. So here in Ontario, the ADP has therapists who become authorizers sign an agreement form, which is about, I think, 2 or 4 pages long. And one of the lines is that we will complete an in-person, full, comprehensive assessment. And when we're signing the application form directly, we are signing that we have personally assessed this person and that the equipment we're recommending is based off the findings of the assessment. But they still don't tell us what that assessment should look like. And if you ask them, they'll say that's a college issue. So I looked at the colleges for occupational therapy, physiotherapy, not just in Ontario, but across Canada. And for good measure, I looked internationally. And I also checked schools for social work and speech language pathology and nursing. And they all say the same thing, that they expect their members to operate in the current best practices that are relevant to the field that they're working in. So I still need to know what those are. So a good place to start is the World Health Organization. And they had a document that came out in 2008, which they updated in 2023. And the good thing is that they are consistent with the other best practices that are out there. So these are what I have found over the years. These are some of the ones that we refer to frequently. They're all available for free on the internet, and I have them saved to my favorites in my browser under a tab called Seating and Mobility Resources. I'm not recommending people read these cover to cover. What you want to do is go in with a question that you're currently facing in your caseload and maybe do a keyword search and read the sections that come up that are relevant to that. And then go back and read it again when the next time you've got a challenge. And what we have found by doing this is that we start to automatically incorporate what we have learned into our practice. So quick review here, RESNA was co-created by a Canadian. It's the Rehab Engineering Society of North America. And they have a number of position papers in their knowledge center that describe considerations from everything for when prescribing an ultra lightweight manual wheelchair to power positioning. Many of you will know the Dalhousie Wheelchair Skills Program, so we use that in the fitting process and training process. Next is New South Wales guidelines, the International Standards of International Society of Wheelchair Professionals. This is the World Health Organization document. Over here at the bottom, in the middle, is the Canadian Best Practice Guidelines on the Prevention and Management of Pressure Ulcers in People with Spinal Cord Injuries. And if there's anybody listening that is ever working on updating this book, which I love, please consider giving it a shorter title because I refer to it frequently. This is one that I did actually read cover to cover because so much of my role is working with pressure injuries and preventing them. At the back in the appendix, they have the Pressure Management Assessment Tool. This was created by an OT in Manitoba to explore the causative factors contributing to pressure injuries that were not responding to typical treatment. It's 17 pages long, but don't let that scare you. It's a combination of interview and hands-on, using your hands to find where are those peak pressures on all the surfaces that a person is using. So, and then at the bottom here on your left, these are the glossary of wheelchair terms and definitions and the clinical application of guide to standardized wheelchair seating measures of the body and seating support surfaces. These are summaries of the International Standards Association guidelines. Those guidelines are 1,000 pages long, apparently. I haven't seen them. These ones are 300 pages long, and we have some therapists in Colorado to thank for this summary. But you know what? 300 pages is still a lot. So what we did, instead of reading it cover to cover, was we called one of the authors and we said, we really like the idea of what this book is suggesting we do, but it's a lot. Where do we start? And she gave us some information, and I'm going to cover that a little bit later in the talk. But right now, I want to start with the World Health Organization. So in 2008, they came out with the guidelines on the provision of manual wheelchairs in less resourced settings. And these were written primarily for policymakers and managers who were going to be developing seating services in developing countries. But they were quickly adopted by academics and clinicians alike for providing all kinds of wheelchairs in all kinds of settings. One of the things that became very popular in presentations since this time were the 8 essential steps in the wheelchair provision process. I really like this document in particular for that because they give you so much information that is useful in creating your practice or enhancing your practice. They have information on what you should be looking for on your referral so you can answer the question, can you address what the person's being referred for given the resources that are available locally, and how to prioritize urgent cases. They state that the assessment needs to be complex and comprehensive, and address the intended use of the device. I like that they have prescription next because it gives you an opportunity to have a discussion with the client on what is available locally that could meet their needs. We do this before we go into funding because if there's not funding for something, we don't know if they have savings that we don't know about, or maybe they want to do some fundraising, or maybe they want to save up for it for later, which is better than hearing them say 5 years later, how come nobody told me about this, for a device that could have had a significant impact on their quality of life. I find this conversation is actually really short in my assessment because I can explain, well, there's this thing, but it's not funded by anywhere and it costs this much. And it's either let's do it or let's move away on to the next thing. Product preparation is the responsibility of the vendor and the manufacturer, but the more information you can give them from your assessment, the better the wheelchair will be set up when they bring it in for the initial fitting. They do recommend that the team be present for the fitting rather than having the wheelchair dropped off at someone's house. There can be a significant period of time between the prescription and the fitting due to supply chain issues, funding not coming in, or maybe the wheelchair user didn't pay their portion, sometimes for months. Things can change in that time. And we as the clinicians are often the only ones that are immune to the expense of a mistake, but we're also the ones that can pinpoint where it might have happened. So if months later, the wheelchair looks like it's not going to work for this person at the initial fitting, did the patient change? Have they lost or gained weight? Or has there been a change in functional status? This may open the door to applying for new funding for something else if their new state is stable. Or did the vendor fill out the order form wrong? Some of these order forms are 14 pages long. There's a lot of stuff that the vendor is paying attention to, and it's not impossible that the conversation between the therapist and the client will take a different direction, that they might miss something. Or did the manufacturer send us the wrong thing? Being able to look at our notes and be able to pinpoint where things went wrong makes it easier for the responsible party to move forward so that the person gets the device they need. User training. So we rely heavily on the Dalhousie Wheelchair Skills Program, and we use that even when we're changing a backrest or setting up a new wheelchair for someone who's been using a device for a long time, because we want to make sure that they are able to use the device safely. And this is a good way to document that. So just wheeling down the straight hallway of the outpatient clinics, we're watching for, are the casters popping up unintentionally? We can go to the ramps and see if they can go up and down the ramp safely, or do we need to raise the foot plate height, or do we need to change the back angle to make the chair less tippy? Things like that. Maintenance and repairs are the responsibility of the wheelchair user. So we give them information before they leave on how to care for their device, when to call for help for service, and the kinds of expenses that they can expect to have to pay on their own because things like tires aren't covered by ADP. And then follow-up. I encourage my patients to use their device as soon as possible. In outpatients, it's not impossible that they'll continue using an older device, but it's harder for us to make changes if we hear about problems 2 or 3 months later that we could have found in 2 or 3 days. So in 2023, we were excited to see that they'd come out with updated guidelines and that they've appropriately changed the title to the Wheelchair Provision Guidelines. What they did here was they made this document more consistent with other publications that they already had for other areas of assistive technology. So instead of 8 essential steps, they went to 4 service step recommendations. This doesn't mean you don't have to do the assessment. It's embedded in the term select here. This is why if you're going to be creating a new practice or you want to check if you can enhance your practice anyway, I would go back to the 2008. I really like the 8 essential steps. What I like about this document are the 3 system level recommendations. And they start off by acknowledging the need for competency in the workforce and that this is a global issue. In my opinion, seating is hard. And it's harder to foster that skill if you're only doing it a few times a year, which is why it's all the more important to make sure that your assessment is going to capture the information that you need. They also talk about the importance of having a smooth referral to appointment process, and they actually recommend 2 to 3 weeks. I have to say I agree with them on that, but the reality is some of the seating clinics wait list times I've heard have been 1.5 years, which leads us to the 3rd recommendation of systematic evaluation. It's important to periodically look at what is the need for service in a given area and how does that compare to the service that is available. Coincidentally, in 2023, there was a review done because somebody had aged out of a pediatric service and found that there was nowhere for them to go. So they got some funding to do a review, and the reviewer interviewed clinicians in clinics and in the community. They interviewed vendors and people from different patient populations, and came out with a report that recommended another seating clinic in the GTA. That's the latest I've heard. I don't know what's come since then. So coming back to training, there are some things that are already established. So we have, of course, the Wheelchair Skills Program that many of you likely know about. The International Society of Wheelchair Professionals is based out of Pittsburgh. And amongst other things, they have a basic certification that you can do online and an intermediate certification. I've got my basic and I encourage my students to get it too. It's something that they can put on their resume. So it can be OT, PT, and the assistants can get this as well. It is based off of the World Health Organization's basic and intermediate training packages. These are 40-hour programs each, complete with slides. These are ready to go for those countries that are looking to develop new seating services. I think that this is something that we could use as a platform for creating new training opportunities. So the World Health Organization's International Classification of Function describes all the components that need to be in an assessment. And the best way to ensure you're covering off everything that you need to is to use a form. So if you do an internet search on seating assessment, you'll find someone who's described what it is and what it should be, and et cetera, et cetera. But if you do an internet search on seating and mobility assessment form, you might see some options that you can choose from. So Sunrise Medical has a form that's 5 pages long. Permobile has one that's 10 pages long. And NARTS, which is the, well, INARTS now, International Registry of Rehab and Technology Suppliers in the US, theirs is 17 pages long. Again, not to scare you off, but just to impress upon you on how it is accepted by experts in the field that this is a complex process. These are the tools that we have ready for our assessment. What you're looking at here is an inclinometer, which we can use to measure a back angle and a seat surface. We've got the large joint goniometer and a protractor square that I found at Lee Valley for $30. So we use both of these for the relative angles, and then the rigid measuring tape and the vernier caliper for the linear measurements. It's also important to take a look at how your patient is sitting and use your hands to find peak pressures or look for, is there uniform loading throughout? Quite often, someone will look like they're seated well from the front and from the side, but from the back, we can use the back kings as a point of reference. So you can see that this person is actually shifted a little bit to the right. So now I'm thinking when I put my hands in, I'm looking for those peak pressures. Often the wheelchair user isn't even aware of this at this point until we tell them. I'm doing this throughout. I'm looking for uniform support throughout the seating support surfaces. So this is another example. What we're doing is we're checking how is this person making contact at the bottom of the backrest versus the top. And I can't tell you the number of times that somebody has come to the clinic saying that they're uncomfortable in their back support. And when I do that, they're only making contact at the top 1/3 of the backrest. It doesn't matter if you don't have sensation or if you have a fusion, that the back of the pelvis needs to be supported to make everything else easier. So this is the framework for what we're using as our baseline is the ideal seated posture. And if you look at this, we're aiming for, the erect spine that is in midline with a level pelvis, femurs that are parallel to each other and straight forward, head balanced on top of the head with gaze looking straight ahead. Without moving, just take a look around the room. None of you are sitting like this, okay? So we don't use the ideal seated posture for comfort or function. When you go home at the end of the day and you're tired and you sit on the couch, it doesn't look like this. You sit on the side so that you can recline and lean on the armrest. We use asymmetry for comfort and function, but we need to understand the impact of that asymmetry that we use because it may contribute to these postural tendencies that we're watching out for. So we've got posterior pelvic tilt where the pelvis is rolled back, causing the trunk to flex forward. And this can actually impede a person's ability to take a full breath. And it will look like this. So the natural line of sight is looking down. So it's more work to lift your head and look straight ahead. We can prevent progression of this with a back support. And that's what we want to do, prevent progression of the postural tendencies, because if we don't, gravity is acting on them all the time and will pull a person further into it. And the further they go into it, the faster gravity will pull them further still. This is the one I'm more worried about, anterior pelvic tilt. So this is when the pelvis is rolled forward. And if it progresses, the front of the pelvis will end up resting on the femurs. So we don't want that to happen. And it usually is with a very lordotic posture where a person probably isn't using the backrest very much because this anterior pelvic tilt is their strategy for stability and function. What's called dump in the chair, where the front of the seat is higher than the back, which will prevent the pelvis from rolling forward. But this is also taking away that person's strategy for stability and function. And quite often they don't like that. We could put a seat belt up in front of the pelvis and mount it at the back canes to prevent progression. Or if the trunk is moving forward with advanced lordosis, we could use an abdominal binder here, also mounted to the back canes. But in my experience, people don't like having stuff mounted in front of them. They want to be seen, not the components of the wheelchair. So if they decline these options, I'm often suggesting my patients consult with a physiotherapist to have an out of the chair plan for preventing progression of APT. Next, we have pelvic obliquity, which is when one side of the pelvis is lower than the other, and it often results in a scoliotic posture. So when one side of the pelvis is lower, Okay. When one side of the pelvis is lower, that bony prominence is already at increased risk of a pressure injury. But now I've got the weight of the trunk over top of that. So it's a pretty serious problem that we're watching out for. And then there's pelvic rotation. So it may be tempting to describe this based on the knees, but that's not actually accurate information. There could be a leg length discrepancy or a hip dislocation. You need to feel the pelvis. And you want to find out, is the pelvis rotated on its own or did the trunk come with it? In my experience, if the trunk is rotated, it's often because the laterals of the back support are too narrow and they're not fitting in it. And so the body rests in a rotated position. However, all of these postural tendencies that I just described are rotational. And where you see one, you will likely see another one. And you don't really want to correct a rotational problem with a linear strategy. You need to take a kind of counter rotational force that is perpendicular, and that's another talk. So, okay, let's get ahead. So This would be an advanced situation where you've got everything happening at once. So you've got a windswept posture with external rotation in one hip and internal on the other, the pelvic obliquity with rotation, scoliotic posture, and rotation. I'm also looking at the feet. So quite often, we've got, if I see toes out and knees out, I'm thinking we might have a height of the foot plate issue, and maybe we need to lower the foot plate or raise the cushion under the thighs. Over here, if a foot's falling off, it could be one of two things. Is the foot support too far back, or is the angle asking for too much dorsiflexion and the foot just can't tolerate it? But before I begin the assessment, I do start by asking my patient, are you sitting the way you normally sit? I've made that mistake where I've just dived in and started defining problems, and the patient goes, but this isn't even how I sit. And it turns out they were late arriving and they were rushed and they did a quick transfer. So now we start with this, and I get informed consent every step of the way. I explain that I'm going to be getting up in the mentally prepare for that. And they might find that they need to share something that hadn't already come up in the interview, like they have a colostomy or something that I need to be aware of. Okay, so we talked about the international standards for seated measurements. And when we called, she said, start with the 3 relative angles. This is them. Trunk to thigh, thigh to lower leg, and lower leg to foot. And we take these 3 angles in 4 places. So I'm going to take this example and show you the 4 places. So the person seated in the wheelchair, the potential for sitting in supine, the desired position on the mat, and then what the current seating system is asking of them. If there's a discrepancy in these, now you have a rationale for changes. Even if I'm changing a back support angle, it's good to say why I'm doing that, right? These are not the same as range of motion angles. This would be range of motion for hip flexion, but that's not really a helpful number for me in terms of building a wheelchair. And that's what I want to do with these numbers. After I have done these angles, especially the desired seated angles on the mat, now I can build a wheelchair or make adjustments to their current wheelchair setting. I'm going to confess, the first time I heard about these, I was not convinced they were going to add value to my practice. But a wise colleague told me you have to try something 10 times before you can knock it. So, okay, I'm in. This was the first person that I did this with. And he came to seating clinic because he was falling forward out of his chair when he was out in the community. So I did the whole assessment. And sure enough, didn't I find that his desired seated trunk to thigh angle was more reclined than what his wheelchair was asking of him. So I asked the technician to open up the back angle. And when he got back in the chair, he said, now my pain is gone. We hadn't even talked about pain. So that's it. Okay, I'm in. But we weren't done there. He was still falling and he had to come back. And we found that his feet wanted to be supported further forward than the wheelchair was offering support. Even when we moved the foot plate as far forward as we could, those casters were kind of behind his wheels. And the base of support there wasn't great enough for where his legs were going to be. We actually had rationale to get this guy a new wheelchair with a longer front end. So then we move on to the supine part of the assessment where we are assessing sitting, but with gravity eliminated. I'm not describing flat out in supine. And we're looking at what is correctable, what of those postural tendencies can move further into that destructive tendency, or can I reduce it at all? So here's an example of 2 of the things that we do in the seating clinic. So here I've got my hands on the front of her pelvis, but I'm using my body to roll her hips. And I'm looking at how much hip flexion can I get before the pelvis starts to come with. And that's not telling me how to build the wheelchair. That's telling me the end limit. If I put too much dump in that chair, their pelvis is going to be pushed back into posterior pelvic tilt. Over here, I'm putting my hands underneath the pelvis and I'm using straight arms to just lift ever so slightly so that I can swing the pelvis left and right, but I'm not looking at the pelvis. I'm looking at the trunk. So in an ideal situation, only the pelvis moves left and right. Okay, that's great. However, if someone has a fusion, I might see that the point of flexion is actually in the mid trunk, or the whole upper body moves with that pelvis. That is telling me my potential for correction or accommodation here. I have had people who sit in a left lower pelvic obliquity, for example, and the only way that they can move is further into that obliquity. If we take, for example, that maybe I can get someone to neutral, that doesn't mean that's where I position them, because the only place they have to move out of that is back into the destructive postural tendency. We want to give them a few degrees of movement in either direction. Next is the seated in the desired position on the mat. So what I'm doing here is I've got my knee right in at the back of the pelvis. Remember I said backrests need to support the pelvis. Same thing here. And I've got my body rotated about 30 degrees, and I'm looking at how much of my leg and maybe trunk do I need to help support this person? Do I need to use my hands? And if I'm using my hands, I'm using them like foam blocks. I'm not using a therapeutic touch. I'm definitely not putting my hands in front of the shoulders unless I'm thinking I'm going to be using straps, but that is so rare in seating clinic. So from here, what I do is I tell the person, we're looking for your ideal seated posture. And I'm going to lean back and forward until you tell me where you feel like you can rest. Where does your head relax on top of your shoulders? And sometimes I find it first. I can feel their whole body just relax, and I might stay there and wait for them to go there. Sometimes I can't find it, or they can't find it at all. So I sneak my knee back about an inch to let the pelvis roll a little bit more into that posterior pelvic tilt that they may need, and try that passive reclining again until we find it. And then we can take our relative angles and our linear measurements. So let's talk about the linear measurements. When I started in seating clinic, there were 3 measurements for prescribing a wheelchair. These are 15. So, and this is the minimum that we use in seating clinic. We do more if we're doing custom seating. So these are the measurements of the chair, and you can see how they correspond to the measurements we do in the assessment. Even if someone is being referred to me just for a new cushion, I do all these measurements every time. It's so useful. Our patients tend to be patients for life, and I can track their changes over time. If someone has come in and lost or gained weight, it's added strength to a letter of justification for funding for a new device. If I can say they're also 2 inches too narrow now for their chair, it's not providing support, they're falling over. I've also been able to catch some things that might need more medical attention by referring to these linear measurements, such as a sudden change in height where they've dropped 4 inches. Okay, so using all this great information, what can you do? Well, you can now share this information with your vendors so that they can better prepare the equipment, so that you're not watching the technician reconfigure the chair, which can sometimes take 45 minutes and really eat up everybody's time. I find doing this, the chair comes in and it's almost ready to go. You have, even when you've finished an assessment and you still don't know what to do, which sometimes happens, you now have information that you can use when you call an expert for help. There's a few therapists in the community that call me from time to time, and they know they have to do their assessment before they call me. Otherwise, I don't have anything to tell them to do. You also have a rationale for your clinical decisions. We can't always get it right, but we want someone else who's reviewing things to be able to look back and understand why we did what we did. And this is what you can get from your assessment. But most importantly is this last point. I can't tell you the number of times I've had a patient say to me, no one has ever assessed me like this before. And even if they don't understand why I'm doing everything that I'm doing, I know that I have started to foster a therapeutic relationship of respect and trust. Okay, so some other tools that we use. You may have yourself or heard of your colleagues doing a hand check on an air-filled cushion. This is the World Health Organization's way to document that. They call it the manual pressure test, and you can do it on any surface. It doesn't have to be air. It could be a foam mattress. It can be a car seat. But it's how to use your hand to help identify peak pressures. I've used this in someone's car seat to show them that it was actually the back of their pelvis, the PSIS, that was at risk, the way they were sitting. And we can use this in our documentation. pressure mapping. So there are some restrictions here. It's only a snapshot in time. It is better at ruling things out rather than it's not intended to be used for equipment selection, but you can use it on a variety of surfaces. But I'm going to tell you, I personally, I get more information faster using my hands. The pressure mapping is by far more useful as compelling biofeedback to encourage clients to understand the effectiveness of weight shifting. And in the patient education session on this, there's actually concurrent videos of a person weight shifting and the corresponding pressure map so that people can see what that looks like. And you want to look for where's the peak pressure, what's the pressure gradient. You want that number to be as low as possible. You're looking for symmetry and dispersion of loading in the pressure map. Okay, the pressure management assessment tools. So doing this a few times has really helped my practice. And this is another one where I'm starting to integrate it into my practice. So two stories here. This person is simulating, it's not actually a person, simulating someone who had had skin flap surgery, and we got them on offloaded custom ride seating that was doing great. Their skin was fine for months, but then in May, they came back like 4 months later with new signs of pressure. So I checked the cushion. It was working as it's supposed to, didn't understand what was going on. Time for the PMAT. Going through the questions, it turned out we're in spring now. Her activities had changed. She was spending 3 hours a day leaning over the side of her chair gardening. So her ITs were not where I was expecting them to be in the cushion. And I was able to make a small change to make the cushion safer to use. This picture on the other side is another colleague simulating someone who was sitting well on a Rojo Hybrid Elite cushion, who was continuing to get devastating ischial tuberosity pressure injuries that were obviously caused by sitting. So the clinical team kept telling him, you've got to get out of the chair. You've got to spend more time in bed. So doing the PMAT, we found out that what he was doing in bed was sitting with his back to the wall, watching movies on his iPad. That was not what anyone was intending at all. We also use a camera in the seating clinic. So I explained to patients that the intended use is there's so much information that goes into this assessment. We might miss something. Taking pictures can help us go, what was on that? Which side was their drive side again? Or, what kind of wheels did they have? And that it's actually recommended by the International Standards Association, where they tell us how to take a picture from the front and from the side, not on an angle. And we've found this to be particularly useful, again, in tracking those long-term changes over time. I've had people a few times come back and say, the only chair I really liked was the one I had 20 years ago. When we look back, the person was an entirely different body size and shape. So it might not work so well for them now. So thoughts for other clinicians. You may find yourself in a discussion with a patient who is dissatisfied with their device. What do you tell them? This is something that one of our students designed as a handout for patients so that they would know when to call the seating clinic and when to call the vendor for service. So this might be something that other clinicians would benefit from as well. Areas for future focus. I have seen that there is growing interest in 24-hour postural care, and I'm adding in habits because of those postural tendencies that we have. You may notice someone in a manual wheelchair drop something on the right side, but they spin around and pick it up on the left side, right? And maybe they're sitting with that safe curvature. And what position are they sleeping in? This is something that we cannot do in seating clinic alone, but I have had success when partnering with physiotherapy on a 24-hour approach. The PMAT, I think, is an underutilized tool, and I would love to see it integrated more. I don't know if it needs to be tested for reliability and validity, but I just think it's something that will help identify and enhance problems and enhance practice. I think we can look at the WHO and the International Society of Wheelchair Professionals for certification and training packages rather than reinventing things from scratch. I would love to see locally models of mentorship for clinicians. So Alberta and New Zealand already have established where the seating clinic partners with more rural clinicians on the initial assessment, and then they provide consultative support as needed later on in the process. And it's designed to kind of train the more rural but local champions, right? So that's something I think would be beneficial in downtown Toronto. Little tidbits that I wanted to share. Long-term effect of abdominal binder use in people with higher level of injuries. They don't tend to have as much of those postural tendencies to the left or to the right. They're sitting straight, and it helps their skin as well. The other thing is rear pockets and incontinence briefs. I'm telling people to use a seam ripper to pick off the rear pockets or buy pants that don't have them, because those seams tend to bisect the ischial tuberosities. I have seen an increase over the last, I don't know, 12 years maybe, of incontinence briefs. And the same thing, the bunched up edges will go right over the ischial tuberosities. Okay, so I've got to stop now. So what I'm hoping is that I've done all this hard work, and I'm hoping the next generation doesn't have to do it the hard way and learn from mistakes, and instead see the value of applying guidelines and resources that were written by panels of experts so that you can start at a higher place than we did in the seating clinic. Thank you very much.
Thank you very much, Marlene, for that great talk. We will now welcome any questions. So if you'd like to raise your hand, if you're in person or on Zoom, or if you'd like to type your question in the chat if you're on Zoom, those are all acceptable.
The same as a question.
Oh, sorry. Yeah.
Any experience reaching, but the main issue that I found is the back. Back rests are horrible. And I think you need to have a new approach to design. Although I try to fix my own back rest, that's where it's very individual design. It's not a universal design for practice. You know this much better than me. But is any approach by this company to get to more rigid, supportive practice? I don't mean steel or metal, just I don't mean that. You need some rigid form or more dense form that fits the exact curve of the back.
Well, so the question for the people online who might not have heard that was around, limited good options for back supports, and, could there be improvement in this area? For sure. There's a wide range of products that are available, and what I understand the manufacturers tend to make are the ones that sell, and spinal cord injury is actually a small part of the market, unfortunately. The other thing that comes to mind when listening to your question is custom molded seating. You jump in price from about $800 to about $4,000. And even then, it's a gamble. And the person has to be willing to work on it, because it's now multiple appointments. I tell people 6 to 9 appointments, possibly. I mean, if we can get it as a hole-in-one, that's great. And even picking the custom molded option, we're looking at what chair we're putting it on. We don't necessarily want to use something big and bulky on an ultra lightweight manual wheelchair, for example. So we're right now working with the options that we have. And not speaking to you directly, but as rather to the question, is sometimes when we can't solve the issue with products, we have to look at positioning, power positioning, angles. It could be those factors as well. So this is where it's really a lot of balls that we're juggling between comfort, safety, and function. And sometimes we solve one of those, and the others get a little bit compromised. So it can be a lengthy process. Sorry, I don't know if that was really the answer. I mean, they have started doing 3D printing for some back manufacturers. So And then there's one that's a lot of moving parts, and you can, in theory, get it all aligned to a specific person's contours. But if one little piece gets loose, now you're in trouble. Or if they decide to fix it, and then they come back and they go, I lost it. Can you get it back? Okay. You know, there's a lot of time that goes into these things. Yeah.
This might be a question specific to me. So now I work in outpatients. I don't do seating assessments very often or never. The three angles and the four different positions that you were describing, is that, and you say that's part of your standard practice now? Is it also part of the standard assessment that the inpatients, like on the
It's on the form, and this is UHN's form. So if you work at UHN, you're supposed to use them. Yes. Yeah.
Because I could see just in, like, because a lot of people come to outpatients with seating problems, their body's changing still.
Yeah.
A lot.
Yeah.
To say that anyone's doing anything wrong, but it would be good for me to know, like, okay, I can try some of these things to try to update.
Yeah, they're on the form.
Needs, but yeah, just to know that.
Yeah. Oh, so for the online audience, it was a question about, are the relative angles on our form, and they are. Yeah.
Marlene, just going back to the World Health Organization order of things, and then how to apply that in the inpatient context when everything is happening so much earlier. I mean, that's the piece I apply for my practice versus now, when patients are often a few weeks post-injury and trying to do that knowing timelines are so tight. Patients are changing, their funding system is precarious. I know it's a bit of a loaded question, but I like how to think through that piece of things, because the team is not dealing with a stable environment in terms of discharge, funding, the person themselves, with knowing so many of our patients are incomplete. So just kind of thoughts on applying the guidelines to a very much a changing situation.
Okay, thank you for that question. And I think you're talking about the equipment selection and funding, kind of that, yeah. Oh, okay. Well, I mean, like, do your full assessment. And, you know, like I said, if the person changes, then you can say, oh, this thing that we were doing isn't working anymore because of this change, right? And if it's not in an assessment, I mean, now I got to look through the narrative of the notes if it's there, right? So it's really helpful to have it in, or never mind if it's me, if it's someone who's covering for you, and it'll show them how the patient has changed and how your idea 2 weeks ago might not actually be the idea going forward. Or it could protect your practice if there's a complaint. So, you know, there was a patient who wanted to buy all the upgrades on a chair, and when it was delivered, he'd already gone home. No one expected him to lose weight while he was at home, but he did. And now this very expensive chair was too wide for him. And he was set to sue. But when we looked at the assessment, we showed him, you know, this was your weight at the time. We compared it to your pre-injury weight, and we thought that was how you were going to be. It made sense at the time. Shut it down. There was no complaint after that. In terms of funding, I don't recommend that you say power standing, and I wouldn't go with all the options right now. You're going with, what does this person need for the situation that they're in at the moment? And the first chair from discharge, it's not their last chair. They're going to come back to seating clinic. They're going to find, you know, at some point, it may not even be 5 years, that things have changed. It's often their environment where we need to reassess what is going to meet their needs. I don't know if that adequately addresses, or do you have another comment on it?
I think it's just appreciating how much is changing. So assessing today, assessing a week from now, and it's the patient, they're progressing, but they might have medical issues. And you know, that what is potentially the discharge location today might not be the discharge location a month from now. So I guess is it is it the right time?
Oh, yeah, no, that would not be the right time, actually.
But
yeah.
The patient needs something to be discharged.
Okay, so if I'm taking an extreme view of that situation, okay, they need to be medically stable, end of story, or at least functionally stable. We expect they're going to need this type of wheelchair over the long-term period. But if there's, what you don't want to find yourself in is scrambling to put together a prescription days before discharge. At that point, you might as well leave it to the community. It would be ideal if the admission aligned with, we got to work on the wheelchair now, right? Yeah, so I've heard that story come up a few times, and it is a real challenge. And even the resources in the community for doing this kind of thing aren't great. And I know other programs that are relying on the community for their wheelchair prescriptions. And I think that's, we need that mentorship program that I talked about, right?
So, but when you do that, it's also then applying that patients are paying for rentals and things like that.
Yep.
We know are also cost.
Yeah. Yeah. And I just want to stress, it's not the vendor's role to solve that problem for us. There's a difference between a loaner and a rental. And I can see in that situation, a rental would be more appropriate if they haven't stabilized and need to kind of get that sorted out first.
Marlene, there's a question online here, if you have a moment.
Sure.
So there's a comment first from Suzanne who says, great presentation, Marlene, so much valuable information. And then there's a question from Heather who says, what is the best thing to do when ankles have the range of motion, but the calves are too tight, forcing the feet into plantar flexion, causing the footrest to appear too high, as in knees out?
So I would make sure that the foot support is angled at the angle that is going to support the feet. And that might be toe down. And then you might need to, well, right. Okay. So you can only lower a foot support so low, right? Before you're hitting the ground. So can you go up under the seat? Right? That might be another way to go. Or is the angle at the knees going to affect that better? If you either tuck the feet back more or put them more out in front, you might buy yourself some inches in height. Yeah. Yeah, or so I comment in the back of the room, thank you, is an opportunity for medical intervention. We don't have to solve everything in seating by ourselves. That is an important thing I've learned over the years.
Okay. Heather says thank you.
Thank you.
A couple minutes left. Anyone has any?
Okay, so if nobody has any further questions, I would like to take a moment to thank Marlene. That was a really fantastic presentation. Lots of important information about clinical application of guidelines for seating and mobility. If you we're going to end the presentation now, but if you have any questions, Marlene might be able to stay for 1 or 2 more minutes afterwards. And as a reminder, the recording of this lecture and previous lectures can be found on the KITE website. So thank you.